I'm a orthopedic surgeon trained at the best orthopedic hospital, does the most knee surgeries in the United States, probably in the whole world. That's a hospital for special surgery in New York. And I was trained in, you know, if somebody walks with a bad knee, there's a way to fix it, and that's surgically. And as time goes on, we've got a lot of other ways of doing it. You can replace the knee, you can take pieces out and put the rest of it together and screw it in place. Meniscal surgery, as you know, is a big thing. When an open surgery, with a big incision in the knee, was replaced by arthroscopic surgery. Medicare fought that tooth and nail, because if you go in through a little pinhole, their position is you can't see what you're doing. And if they go home the same day, then it can't be surgery, because nobody goes home the same day. So for years, they would not pay for arthroscopic surgery, and then they wouldn't pay unless they stayed in the hospital. Now they've changed, they won't pay if they do stay in the hospital. I was, after, as the brochure said, after 10,000 knee operations, I was happily moving right along. I was doing, maybe 10 a day, several days a week, and I didn't know there's any other way. And it was purely by accident that a woman came in with, who I'd already, with advanced arthritis, but when you have arthritis in your knee, this muscle on the inside of your knee doesn't do its job, and the remaining part of your quadriceps, this is 4 muscles, pull your kneecap to the outside, and you've lost the balance from the inside. You have a constant pressure by your kneecap to the outside, and that leads to a disaster. See, I have some, if you, this is a knee, this is the thigh bone, the femur, this is the tibia. If you open it up, there's a passageway in here. That passageway fits, the kneecap fits in there like a ship in a channel, except almost invariably, because the knee doesn't change, it always does the same thing time after time. And you know what it's going to do. This kneecap starts to drift off to the side, and it clicks and it pops, and the stretch, because it has to go through an increased range of motion, the stretch gives you a patellar tendonitis. So your knee sometimes feels weak, sometimes you have pain behind the knee, to either side. And then, by chance, you may have arthritis in the knee. Arthritis is a loss of the cushions. Cushions are this is your femur, and down here is the tibia. There's the outside. And then here's your kneecap right in the center. And your kneecap attaches down here. So you've got a tendon going from the kneecap to this little, to this point on the shin bone. Normally you've got some attachments going from the kneecap down to the tibia, and on the other side from the kneecap going over here. Let's look at the kneecap in a different way. Instead of here's your kneecap, it has a groove, there's its channel. But it has a blood supply and nerve supply on both sides. and this go down and attaches here. On the outside, now you've got some real power. This goes down and attaches on this side, and every time you have an injury or you're laid up for a week or two, the inner side, this muscle called the vastus medialis, gets a little weaker. These get weaker too, but these come back, and this doesn't come back. So even if you have rehab, after your surgery, after your illness, whatever they may do, you never get it all back. Then if something happens down in the tibia, where all of a sudden you've lost your cushion, and you have bone touching bone, that is what we call arthritis. But no matter whether it's on one side or the other side or both sides, your kneecap always goes to the outside. You have a constant pressure pushing on the outside. So here we go again. In essence, the same thing. Here's your kneecap, but now it's coming over here. This is the inside where you don't have the muscles. It's being pulled to the outside. So the end result is this part starts to get arthritic. And it comes over and it builds up in here, and then you get a spur, and that spur is pushing the kneecap over. The kneecap, which is now pushed over, that is developing arthritis too. And this is coming up to accommodate the kneecap, which is over there. So now you've got the kneecap sitting over here with all this new bone and this pushing it over. So this is resistant. You can't start exercising and think that you're going to overcome this spur here and these spurs, the spurs on the other side. The solution that we always do is called a lateral release. Lateral means the outside. So if you cut these attachments on the outside, that allows the kneecap to settle in. And that sounds pretty easy, and it is easy. I could do it in 5 minutes. But the complications, now we're talking. So this is a very bloody operation. Your knee swells up, and this swells up enough so that you're going to get swelling down your lower leg, and it's very easy to get a clot. You throw the clot, now you've got another problem. Or you throw the clot up in your heart or up in your brain. I had one fellow, I told him I'd stay on crutches, stay on crutches, stay on crutches. Instead, he went to Tampa. He drove up to Tampa. By the time he got there, this is about a day and a half after surgery, his leg was sky high. He got the biggest, bloodiest knee you ever saw. And when he came back, he'd already been hospitalized there. The clots were so bad, he had to put what they call an umbrella to stop the clots. The umbrella inside of his major vein to block them from going to his heart and up here. And he said, "Doc, geez, what'd you do to me?" And so when he said, "Yeah, all I did was drive up there," I said, "Don't drive up there. You can't go. You can't put weight down. You can't." Yeah, but Doc, I didn't know you were serious. And that's why somebody wear a white coat. You know, that kind of helps. You say, I'm not kidding. I'm telling you, you can't do this. But if I never make those cuts in the first place, I don't have any operations. So I'm now 10,000 patients I've treated without surgery, and I've had no complications. I have no clots, nothing else. Your knee doesn't like this pressure, so it develops fluid in the knee. You relieve this pressure, and the knee will stop swelling up and it'll spontaneously go down. I rarely have to tap a knee anymore. When In the good old days when I was doing surgery, and the rest of the fellows doing surgery, what the kneecap has a cover. This is called articular cartilage. And when this wears down, because it's rubbing on the bone over here because of pressure, you lose that cover, and this part loses its cover, and you've got bone hitting on bone with the kneecap hitting over there. This kneecap, which is sitting over here, has all kinds of bands which come over here, and you have no bands on this side. So here's your cut, you go right through there, boom. But if you don't cut it, you can stretch this out. You can lift the edge of the kneecap, which is coming over in here, and figure this developing spur. The spur comes down here and it meets all this arthritis, and the blood vessels which go there, and the nerves which are underneath your displaced kneecap are no longer normal. So here's your kneecap off to the side. This goes off to the side. The arteries, the nerves, all changed. And a fellow in Spain put on a slide, he took the sections that were removed by some of the students in Spain and looked at under the slide, he saw that the arteries are deformed and the nerves are deformed. The nerves all look like a neuroma. A neuroma is when you have a nerve which is cut. If you cut that nerve for whatever reason, by accident, you slip a knife and just a little bit underneath the skin, you would divide a little nerve, you can barely even see it. So this nerve tries to join that nerve. But it can't find it. So you get there are hundreds and hundreds and hundreds of little branches. These things start looking for that. This branch starts looking for that one. And this whole thing then becomes a very tender spot. And you tap it anywhere along here, you get shocks going up and down your knee or wherever the neuroma may be, whether it's in your shoulder from surgery, your hand, your wrist, wherever you may have cut that nerve. So let's change your sheets again. So here's the displaced nerve, here's the bone, and here's where the nerves are coming in. These nerves and the arteries are getting squeezed as they come in here, and they're squeezed for year after year after year. Once I lift this up and try to stretch it and get it over here, and then move that kneecap down the channel. The first one I tried to do was for the first years, just to lift this up. And that kept people, I'd have to do it maybe 3, 4, 5, 6, 7, 8, 9, 10, 15 times. And that's discouraging to me and to them. But as time went along, I got better and better and better at doing this. And so now, maybe a third of the visits I used to take, and people get well now and solve this problem within 2, 3, 4, 5 visits. Once I freed this up and manually move this kneecap down into that channel and rub this area that had these screwed up nerves and screwed up arteries down into that channel, other things start to happen. When I just moved it in a little bit, Well, people would tell me, gee, the numbness in my feet seems to be going. I paid no attention to that because it didn't make any sense to me. But you've heard of peripheral neuritis, both in the hands and the feet. And so as I started to move this kneecap down into the channel where it hadn't been in years, the people had a strange reaction. After I've done that, they get a little dizzy, something happens to them, but the nerves start to come back within 24 hours, or something. By the time they're walking out, they can feel that they're getting feeling back in their feet. And all of a sudden, the tingling and the numbness and the burning starts to reduce. As time went by, when I first started off, it was, as I said, it was an accident. And the first woman, she was scheduled for surgery, and she had this cover of the kneecap. Is this red showing up at all? And she had a hole in there, and that matched a spur here. And so her kneecap, this spur got in that hole, and she could not get unstuck. And so I had to wait, I was waiting for the post office to give the okay for surgery. I've got to do something. So I injected a lot of Novocaine in this, and I was able to lift it up and get it off of that spur. But then she said afterwards, you know, Doc, I don't, my pain's gone. I figured, well, that's because of the anesthesia I put in there. I said, you come back tomorrow and you'll find you got the same old problem you had before. You just got hooked up on that spur. Well, she came back the next day and said, my pain's still gone. I didn't believe it, because this can't happen. This only gets solved if you cut that. Came back the next day, and she still was well. And then I decided I'm dreaming. This is not really true, because I have been well trained. I've studied hard, and I never read anything like this. But maybe it's true. So I searched the world literature. I mean, I went through Scandinavia and Africa and Greece, everything. Nothing about manually stretching out. There are books written about how to cut this, or how to knock this piece off, or what to do, but nothing about manually stretching it out. So I thought that was all I was doing, is stretching it out. But actually, I worked in, so I injected everybody then. So for the first 150 people, I injected them all, and then couldn't do that. I thought it hurt too much, but then I was working in Cuba for 10 years. I was operating there, doing 6 or 8 operations every day that I would be there. I was going there once a month. And one woman, after I'd learned this, said, no, 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 to eject a knee or anything else, you have to go to the operating room in Cuba. And I'm not about to admit all these people, which I can just put a little shot in, right? But I'm not going to inject her, you know, in her home. I guess I could at somebody's house, I don't know who, but. And she was really pitiful case. She had a stroke, and she was bent over. She couldn't hardly walk. So she insisted, and like broken Spanish, we got together, but I do it without anesthesia. And I said, oh man, this is too much for you, you can't handle it. She kept pointing at, do it, do it. And I did it without the anesthesia, not a word out of her. And then she stood up, she starts to walk, she starts to cry, and she's really zipping along there like she hadn't gone in years. And then she sits down, still crying. She crosses her leg over the other, which she hadn't been able to do for years because of her kneecap. Boom, off she goes again, crying again. And she was one of the lucky ones. I just treated her one day. I saw her year after year, never had to do anything else. Rarely does that happen, that one visit will do it. But it does happen. Sometimes I get it at one time and that's the end of it. But what is more important is Here you've got the thigh bone touching the tibia. All the cushion over the tibia is gone. All the cushion here is gone, and now you have arthritis. So I would usually x-ray the people before when I first see them. But then on some of the, on a man who'd been injured on the job, I just decided to take a picture of him again 2 years later, and I found that this bone was no longer touching. What I'd been doing is breaking down the attachments from the kneecap to the femur and the kneecap to the tibia. Then I didn't have to do anything else. As I got better and better at doing this, the knee will take care of itself. If I break down the attachments on the outside, kneecap to femur, kneecap to tibia, the knee will right itself. So before that, it was progressive, everything getting worse, and all of a sudden, where you've got no cushion, the weight on your bone is transferred from this side of your knee to the good side. So this opens up and this closes, and you've got good bone here, good bone there, or better bone. So by transferring the weight over there, the pain goes away immediately. I could never understand why their arthritic pain went away. There's something called referred pain. So if you have a heart attack, you don't always have chest pain. You may just have pain in your arm, pain in your stomach, pain in your back. So I just assumed, well, that's just whatever I assumed, I was wrong. I was actually changing the relationship of these two bones by changing the relationship by weakening all the attachments. Now, pretty easy. After a while, it got pretty easy to break down those attachments. At first, I never dared cut them even when I was doing surgery, because if you do too much, then the kneecap starts flipping out of place on the wrong side, the other side. Then you got to go back in and reattach it. I had never done that, but I had been reattaching the ones that the other guys had done. All right, the next page. When you have a knee replacement, you've got the same trough. We're now looking down the shaft, and we see you've got a metal piece in there, and the kneecap is supposed to be here. Instead, it's over there. It's not fitting in the trough. So you've got this metal hitting this bone, and these people, in effect, are having a tremendous amount of pain. They can't bend their knee because this is rubbing on that. And so they take the obvious treatment, they take them to the operating room, and they bend it forcibly with the patient asleep, and that generally does nothing of any real importance. It gives you a little more motion, but the amount of bleeding and pain they have afterwards, it just knocks out, you gain nothing. When you make the incision to replace a knee, you make it on the inside. So you make the incision over here to get to replace this and replace the femur. So you've got metal on metal, but you still got the kneecap going over to the side. So you further weaken what little muscle you've got on the inside, and this is still intact. This is still bound down. And so that's a failed knee prosthesis. They'll go back in, they may give you a whole new kneecap, they'll take it and do the whole procedure over again, when all you've got to do, and I've had pretty good success on fixing failed total knees by just the same thing before. Get this elevated so there's some space between these two surfaces, and immediately the pain will go. When the operation is done, it's done with your legs straight out. And so it looks like the kneecap is in the groove. But as soon as you bend it, these things pull the kneecap right over there, and you got your pain all back again. For a torn meniscus, in the over 30 age group, the chances are good you tore it long before you think you tore it, so you have a knee injury. I jumped off a bicycle, some person was heading right at me in the wrong side, and as they went by, they said, "Watch where you're going." And I jumped off my bicycle to keep out of the way, and I'd hurt my knee. So it was hurting. I had an MRI, and it showed I had a couple of torn cartilages there, a couple here. So I did the same thing to myself I'm doing to everybody else. My pain went away. I've still got the torn cartilages, but in the over 30, 35, 40, 45, 50 age group, that's not hurting you. But you've got these bones pressing on that torn cartilage. The kneecap always sins, always does the same thing, time after time. It goes to the outside, you free that up, let the bones resettle, and they'll take the pain, the pressure right off that side of the torn meniscus and put it on the other side of the knee, and the pain's gone. So I've had no pain in the 3 years since it happened. But people come in, I've got a torn cartilage, you've got to operate, I said, no. When I went to Cuba, I was operating, as I said, every time I went there. Then once I figured this out, and I did several hundred cases, I thought, okay, now it's time to go to Cuba. So when I get there, they go to, their orthopedists have already chosen the cases I'm going to operate on. So they're all in the recovery room, they've all got their IVs running, you're all ready to go. And I just went around from table to table, moving the kneecap, getting it readjusted, going there, and they all got up, and they all walked along, the pain's gone, pulled their IV, and they all went home. And they all give a glare, like, what'd you do? Because it's hard to believe that you have that much pain for that long, and all of a sudden, somebody just makes some maneuvers in the knee. But it doesn't come easy to make these maneuvers. It took a lot of operations, a lot of looking at what I'm doing here. The word for when you've got a bad surface is called chondromalacia. It's articular cartilage. And once that goes bad, and so the doctors or the MRI will show chondromalacia. And you walk in, I got chondromalacia. Well, I'm sure everybody in this room's got chondromalacia. We all don't need surgery. And so, in my prior days, you take a laser, you go over the surface of the chondromalacia, and you smooth all that down instead of a rough surface. Now you got a nice, smooth, firm surface, and they feel good for a month or 2 months or 3 or 4, and they get all their symptoms back again. Because you didn't solve the problem. You superficially think you did something because you smoothed the rough edge down, but you didn't get rid of the deforming factor in the knee. And since then, as I moved this kneecap further down, by the way, a lot of you, I kind of ran out of handouts. I gave you a bunch of x-rays. For those of you who have it, if you look at the first, if you look at page 1, you see this is a view where the person just standing still. You see the thigh bone at the top, and the tibia below, and between the two you see a space. That space is occupied by the cover of the bone above the femur, and the cover of the bone goes in the joint plus the meniscus in between. So as I jump up and down, these absorb the shock. These are a shock absorber. If you go to page 2, if you look on the right-hand side, you look at the left knee. Now, if you look at the other side, you still, these are terrible prints. They're right from where it came out, whatever it is. I think this one was probably today. Yeah, it's the one I saw today. So she comes in, she only has a problem on one side. There's good space on the other knee, but here you see bone touching bone. So what I have done, had I went ahead and x-rayed her, after I treated her, you'd see that I opened up that space, and now she's bearing her weight on the side that has the opening. If you go to page 3, on the right side, you see a normal knee. Is this her? No, this is someone else. You see a normal knee. You see the kneecap sitting at the groove. But look at the other side. If you look at the side facing the good knee, you see that big, looks like a Gila monster coming up. And that's growing up and coming over and pushing that kneecap to the outside. And on the outside, you see a large flat surface. Most of that is all new bone built up to flatten it out to accommodate the kneecap, which is pushed to the outside, and this side is pushing it over. But this view is called a merchant's view. And usually, when you go to the doctor's office, you take a front and a back. They don't take this view. When I showed you the narrowed area before, they take a front and a back. What you've got to do when you take that picture is squat. And if you squat, that emphasizes your arthritis. And you'll see bone touching bone, so you think there's nothing there. You just take a plain old, you're lying down and your leg in the x-ray shows a good space until you step on it. And then you find out what the real problem is. The fourth picture is more of the same on both knees. If you look at the one on the right side, you see a big spur. The kneecap is the one that's sitting with the kneecap. You've got this spur coming down, and you've got a buildup of bone. Right beneath that kneecap is all new bone to flatten out the surface to accommodate the lateral split strip. And on the inside, especially on the other picture, you see it coming up like the same monster coming up and trying to push it to the outside. And the next page just has more of the same. On the inner side, I'm referring to as the medial side, you've got this big monster pushing the bone over, and you've got an overgrowth of the normal bone on the outside of the knee to flatten that surface. All right. So, as one of the side effects, I don't have no side effects. There are other things that can be wrong in the knee. There may be something called pseudo-gout. That's where you get some speckles of calcification inside of a meniscus. The meniscus is a slang term for cartilage. I tore my cartilage. But they're not talking the lining of the bone, they're talking about the meniscus. And that may get irritated by what you're doing. You get some fluid in the knee. Most of the fluid comes because the kneecap is rubbing the wrong way. But as I got better and could then really concentrated on breaking down the attachments of the kneecap to the thigh bone and the kneecap here, allowing me to settle down. Now, it's true, I'm changing that. But as I'm rubbing this down, I'm getting way down in there. All of a sudden, for the last, 9 months, something else has been happening. Remember, we've got messed up nerves and messed up arteries, which I mentioned before. And rubbing those together causes people with fibromyalgia, chronic pain syndrome, rosacea, irritable bowel syndrome, some of those autoimmune. As soon as I finish that and they stand up, they get a flush. You can just watch it. It starts down the legs, it just marches up, marches up, marches up, and they actually feel a little, they gotta hang on to the bed or something. They get short of breath, and this is more in women than men, but they feel like they're having a hot flash. But immediately, all their symptoms of fibromyalgia, all their symptoms of chronic pain syndrome clear up. And so a person with neuritis of their hands, their elbows hurt, this, that, boom, like that, everything's gone. Some of them who are, now from here, I have not followed a lot of these people, but the few I have followed, because first, the government doesn't believe what I'm doing is working anyway, despite 10,000 cases. And now for me to say, well, I can fix fibromyalgia, all I gotta do is rub the bones of the knee together. Ha 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 ha! I'm kidding. They'll send the police after me, and I'll be with that guy skipping from country to country, trying to avoid. So I don't even tell them. All I know is I can do it. Now, that first came because a woman who did have those things did still have bad knees. And her big desire was to dance. So I had her knees bent and she said, "You can dance, that's great." Yeah, but I've got fibromyalgia, that means nothing to me. And then she came in a couple of weeks later for her knees. I danced for 2 hours, then I danced all night long. I got nothing wrong with me. So I began to listen. I said, well, send in a couple of your friends who got the same problem. They can't dance, let's see what I can do with them. And so all of these people do have something wrong in their knee. Now, for the first 8,000 or 9,000, I was not solving that problem. I was solving neuropathy, the feet. I can get, if you have peripheral neuropathy, I can get 85% of people 85% better. Yet some don't care about it, no matter how bad they are and how they walk. They're resistant to having anything done. I don't even charge you. I said, come on, I'm not going to charge it. I'll just get rid of it. No. One fellow walks along, boom, falls over the chair. I said, I can solve that for you. No, I'm okay. Don't you worry, I'm okay. And it's the same. Now, your experiences, I'm sure I've heard some of you are solving, I don't know to what degree, fibromyalgia, chronic pain syndrome. But for me, I'm getting well. They don't really care to stay 100% well. They're going to some of you who keep them kind of good, and they'll do that. But to get rid of it all of a sudden, no, doctor. No. They've got a life. They've got a husband or a wife who's like a care guardian for them. And as soon as that husband says, "Oh, you're looking real good," boom, that's the end of that. I'll never see them again. A lot of these people are on disability. And all of a sudden, if you're totally disabled and you can walk, I'm free. No, but like a deer in the headlights. What have you done? I never see them again. Never. They never come back. I'll call some of them, like the irritable bowel syndrome. How is it coming? Oh, it's doing real good. I haven't had any problem. How are your knees? Oh, yeah, a little problem, but they, you know. So I can't explain that. Do I have failures? Do I have failures in treating people with these needs? No, I do not. I have 100% improvement. That doesn't mean that 100% of people think they're well. So you know, you can say you're good, you can say you're not good, but how do you prove it? Well, the Journal of the American Medical Association had a nice article about a year and a half ago. If you measure their gait speed, that's the speed they walk at, and they come into the office walking, they're bent over, they rotate out, and they've got this, you know, duck waddle. And you treat that knee, and 4 or 5 minutes later, you know, it gives you goose pimples to watch them. They straighten up, and all of a sudden they're 5 inches taller. Their knees are straight. Instead of rotating out, now they're rotated straight. They've lost the waddle, and they cry, the family cries, everybody's happy. But not everyone. I had an Eastern Airlines captain. He comes in that way. Came in the same old thing, up, oh. And I said, I'd like to take some x-ray. You're not going to take x-ray. You've done nothing for me. This whole thing's a fraud. I'm getting out of here. Full body marches. And some of them are really mad. They'll write to Medicare, they'll write to anybody saying, boy, oh boy, I went there and they did nothing. You can say, well, look, let me show you how you walked when you came in here and how you're walking now. Because I photographed them getting up from a chair instead of having to, you know, God damn. Now they're sitting down, whoa. And the most of them, oh yeah, this is great. But not the ones, and you, again, I've got photographs of the way they, I mean, a movie of them struggling and fighting to get up, and they jump up and walking and say, you've done nothing. I'm the same as I walked here. In fact, I think I'm worse, doctor. Okay, here's your money back. Goodbye. But why is that? Let's skip the secondary gain. There is another factor in people not getting well. It's called the hypothalamus. It's part of your brain. But you know, you try to explain this. So what are you telling me? I'm crazy? I'm not crazy. You're crazy. But this, the hypothalamus controls, it sends out the message that you're in pain. If I make the pain go away, and about 1% of the people, the hypothalamus doesn't know it. Or if it knows it, heaven knows. So we know they're better, but the hypothalamus says you're no better. So a lot of them have an ache here, and because they're functioning so much better the next day, their thighs hurt because they're doing things they haven't done for years and years and years. It's like the first day out for, you know, volleyball practice or football practice, you're wrecked the next day. And as far as they're concerned, I've made them worse. They don't understand it. Why do I say that you're better? So well, why don't you look? Let me show you your video, what you were like when I met you. I don't want to see the video. I know what's going on, and it's not my brain. I'm not crazy. You're crazy, doctor. All right. What else do I want to say? There are a lot of other solutions. I don't need to do anything other than manually change the way your bones meet, and I change enough of the connections there, and your body takes over and changes you to a better shape. But you go out, I want at least 3 visits. You go out after the first visit and climb up the roof and paint the house, and you come down, doctor, what'd you do to me? It's like a cogwheel. Things gotta fit. Your body will fit in there, but you abuse it before it gets really set in there, and you lose everything I gave you. So you've got to go easy for a couple of days until you get settled in. And then you start back to doing the walks and the running or whatever the activities were, but you gotta give it a chance. There are other solutions, and I've done all the other solutions. There's, well, there's the cell transplant. So if you've got a, if you've got a nice cover, and here you have a hole, we can take a biopsy from here and send this to Boston, and Boston will grow the cells out, and they send them back to me, and then you get a little piece of the tibia, and you sew this on, leave a little hole, and inject those cells into here, and you will build a new cover, but not as good as what you had to begin with. But some people feel good for a year, 2 years, 3 years. But these are not working satisfactorily enough so that I cared to do more than, what, half a dozen of them. And I didn't hear good reports. One man may have about it good, and others, so it's not a reproducible benefit. So if it isn't, I'm not gonna do it. Now the other way is to take, here you've got a hole, you take a whole plug out. You take this plug and fit it in there, and this, you've got to make sure you got a nice smooth surface. That doesn't mean that plug's gonna stay there. So that comes out, and I see one of these, what, every 10 days, where either something went wrong here, or something went up there, but all of a sudden, so the last one I saw, we just did an MRI on him, and we see that he's got a drop-off again, and his knee will catch. So either this has been worn down, but whatever, even though it's there, it isn't as good as what you had. So this is called an Oates procedure, osteochondral transplant. The day's going to come that there will be something, but we don't have it yet. And some of these cell therapy, in some of your lifetime, it's going to happen, but it's not here yet. So we can't give you what you've lost. We can replace it with something not as good. I'll just show you meniscus. Here's what a meniscus looks like. When you look at it, there it is. It's attached to the bone out here. It may, you may have a tear like this, or worse, a tear like this. This is called a horizontal, or this is a potential bucket handle tear. This whole thing will slide out, so that now you've got this whole thing stuck in the center of your knee. Sometimes you can snap it back, other times you can't. With that, you can't get straight, you can't bend it. You got to get this little thing out of there. That's all there is to it. In our age group, which is everybody here is over 15 or 16. At the younger, maybe you've got a blood supply here, then you can push it back and sew it with a good chance it'll take. But mine's not going to take, and most of yours not going to take, because we've only got about 15% where there's a blood supply. No blood supply, no heal, no solution. Tears like this don't matter. This is called a radial tear. These don't hurt unless this extends up like that, and now you've got a flap which you can come in and out of place. If that flips on itself or gets caught, fine, that's the end of it. You don't have to do something because it's there. You don't have to do anything here if that doesn't open up. If it doesn't hurt, leave it alone. You're doing no damage. So I've had this, and I could not unlock it. Nobody else could unlock it. I had to have this little thing taken out. And the doctor said, you'll never run again. And that was, what, 15 years ago, and I'm still running every day. So most of the time, don't believe all the doctors. You know, I'm a good example of paying no attention to what they say. If I can see it for myself, there are a lot of other things which are done in these. There's a lot of, and I'm sure a lot of you are treating these in different ways. That's fine. But if you fail and you can't get the job done, I'm your man. Everything else fails, I can probably solve it for you. Again, the incidence of numbers I failed are almost infinitesimal. I reduced the number of total knees probably by 90%. Because if the people come in, no matter how much bone on bone, no matter what it is, I can get rid of it. I can reposition the bone. But then can you hold it? I can't hold it on some people. So about 90% of people, I can get them good enough so they never will have a total knee. 5% I can't hold it long enough. And the other 5%, they want something done because their leg's crooked, they want it cosmetically done, or they want, one woman wanted to prove to her boss she had a bad knee. Even though I got her well, I said, no, I'm going to show him. Well, she showed him over. She's in a wheelchair for life now. She got everything wrong. She got infected. She threw clots. She's in intensive care. Can't walk, can't do nothing. There are other solutions that you have. I've tried out most of them while I was operating and doing everything, trying to get good solutions, trying to avoid surgery, and this is what I've accidentally, serendipitously came upon, and about every 6 months I get a little better, and I get a little better and better and better. And that's all I have to say. I will entertain a few questions. I can't really see who's got their hand up. Can you sit down and just point to somebody and then do a question? I'm going to repeat the question.
Okay. If someone has no knee problem, has no pain, or maybe has diabetic neuropathy in their feet, or you even mentioned irritable bowel syndrome, if you correct their knee, even though it doesn't need correcting, can you relieve those situations?
Yes. Just because there are a lot of people, when they develop knee pain, they've had their knee get worse and worse and worse for 10, 15, 20 years. And finally something happens, they reach a point, the straw that broke the camel's back, and they've got a problem. But if you examine the knees, like today I had a woman, she wanted to see me for her right knee. I could have sworn it was her left knee. Her left knee was hot, it had fluid in it, all of that thing. She said, no, there's nothing wrong with that knee. Well, of course there was. So, people who say there's nothing wrong with the knee, as far as they're concerned, like the first man who took care of the peripheral neuropathy, I was working in the Cook Islands. That's way on the, it's as far in the South Pacific as the Hawaiian Islands are from the equator, that far over. And I was seeing the knee problems. I used to operate there, but then I got people so well they didn't need any further surgery. And one comes in because he's got the peripheral neuropathy. And he wanted, because I cured his buddy who had a bad knee, he wanted me to fix him. I said, I can't. You gotta have a bad knee. I thought, oh, let me just take a look at it. Well, he didn't have a good knee. He thinks he had a good knee, but he had a bum knee, and the same thing, his kneecap was over. I got that solved, and it's perfect, and he got solved. So just because you think your knee's good doesn't mean it's really good. I may be loaded with cancer, but I don't know it. And by the time I know there's something wrong,
Too late.
it may be well too late. Maybe I got it in time, maybe I didn't. But thinking you've got a good need doesn't mean it's really so. Yes, ma'am.
A lot of orthopedic doctors are giving hyaluronic shots in the knee. Do you recommend that?
I love them. I used to give a lot of them, until I got smart. Now I only give maybe a 50th of what I used to give. Because I can get them better than that shot can get them.
What kind of shot?
We're talking about hyaluronic acid, but that's called Hyalgan and Synvisc and Suparts. They're all doing the same thing. They're taking the articular cartilage, the lining of the bone, and getting it kind of revitalized. There are very few cells inside of the lining of the bone, and this makes them better and makes them act like a cushion again. It may last for 3 months or 4 months or 6 months, but it's not a long-term solution. Some of the people I saw today, one I hadn't seen for 4 years, no, I hadn't seen for 2 years, and done well till a week ago. But if I can't do anything in the last resort, I can't keep them long enough, I will still give. I prefer the Hyalgan because even though it's 5 shots, there's no complications. The others, wow, if things go wrong for you, you're in big trouble. But yes, I still use it, but nowhere near I did. I'm better now than I ever was giving Hyalgan. I can't see, but it looks like 2 people together.
Can you do that procedure on the knee if you have if you've had a lateral release, with arthroscopic surgery?
Yes,
You can still.
sure, because the lateral release, if they don't give you the proper care afterwards, it goes right back together again.
Oh.
Right. So having a lateral release doesn't mean you still got a lateral release.
I
The
see.
kneecap, by the time I was doing it, I wanted to return the kneecap, instead of just a little thing like 90 degrees on its side. And if you can keep it so it goes up 30 degrees, you've got a success. But I have operated a lot of ballerinas. You can fix them, and very few of them ever go back and are ballerina. They become ballerina instructors or some other side thing. They never get good again. Where the way I do it now, now they go back. They're back within usually a week or 10 days. I had a featured dancer from the Havana Ballet a couple of months ago. Couldn't fix her. She breasted, nothing worked. And in minutes I had her dancing and jumping again. Yes, your companion of that other woman. Go ahead.
My mother's 90 years old and she's in a wheelchair. Her knee is bone to bone with arthritis. She's also got neuropathy. Would you be able to help her?
Probably.
Good.
Not possibly. Probably.
Okay.
Do you
Yes,
do
sir, with a white shirt.
Do you do anything with rotator cuffs?
No, I'm strictly knees. I used to be strictly backs, and then back surgery. I do my backs, and there's a whole bunch. One of the good things about what I'm doing now, when I push it way in there, especially people who got the fibromyalgia, who got neck pain, back pain, all of them will go away except where you have a frank lesion. So having done hundreds and hundreds of back surgeries, I had one the other day, I got her knees good, so she's walking, but she got rid of, your body can't handle that kind of walk, and your back will go. Fixing the back doesn't go any good. Fix the knees, get a good walk, and then if you still got a problem. So for this one, she'd had a fusion. She had a little fracture, and for some reason they fused the 3rd to the 4th lumbar vertebrae. But her whole back hurt. Well, that's unreasonable. Once I had done this, all the pain went away except where the lesion was, and it was the bottom of the bottom of the fusion sheet had, bottom of the middle. So that's where you expect it to get weak, where you've got a fixed, your back won't move, and yet you've got some motion below it, you've got a fixed pelvis. It should break down either above your fusion or below your fusion. And so then I could pinpoint where it was. And so I sent her off, then knowing where it was, off to a fellow to do what he could to get it better. Next question.
Yeah, Doctor, are there activities or exercises that are good for your knees in that area, and are there some that are detrimental to that area?
Yes.
There's some to be avoided and some that we should do.
Yes, kneeling on your knee is murder, no matter what you think. You're making it worse. Putting on a band or something, makes you think you're doing well. You know, your motion is already restricted because of your bum kneecap. It's malposition. When you put the band on, you're pressing that kneecap against the bone, and although you think you're better because it doesn't move as well, you're actually injuring yourself. So the people I see, I get them better immediately, stop the band, and nobody's ever gone back to the brace after that. Yes, ma'am?
Up and down stairs, what's your experience with that for your knees?
Everybody with a knee problem, when you have to go up and down stairs, your kneecap, which is off to the side, rides over there. The more stairs, the worse you feel. You get this thing over there, and up and down the stairs you go.
So it is okay if your knees are okay to go up and down stairs?
Sure. If your knees are okay, I don't care what you do. If they're not okay, you're not okay, you'll find out soon enough. Yes, sir.
But you said that the muscles on the inside of the leg somehow are getting weak, and that's why it moves, flips over to the outside.
That's right. 4 muscles of quadriceps, the inner side is weak. So if you strengthen it, that's part of the question I was asking someone else. If you strengthen that one, it isn't enough to just do a squat, but if you do a squat and rotate your foot in, kind of like a pigeon toe, you really, and think about what you're doing. And think it, you can feel that muscle, the vastus medialis, you can feel it. And then you constantly, come on baby, get up, get there, get there. And faithfully do that 20 times, 3, 4, 5 times a day. I usually do it, my knees haven't hurt in, 3, 4 years, but I still do 60 to 120 of those a day, every day. Every time I'm in an elevator by myself, boom, another 20. Up and down, 20.
But you are bending the knee, right?
Yeah, you're squatting up.
You're squatting down.
Yeah, but not down like this. When you get all the way down, now your knee goes too far over. So when you're lifting weights in the gym, lift. When my knee's straight, that's 0. Here's 90 degrees. Forget that. Lift 45 to 0. 45 to 0. That's all you do. Put a block on the machine. Even the curls, forget getting all the way up there. Your kneecap goes off to the side. You're not getting the muscle lifting it from 90 to here. You can feel your own set, but as soon as you go from 45 up there, now your quadriceps working. But that still leaves you in balance. You've got to do something to get this stronger than those. First you got to get your kneecap loosened up. Then you can exercise. So we teach almost everybody to exercise, doing how to do it. And we go over with them every time, make sure they're doing it correctly. Yeah. I can't see you, so.
I don't understand how you can move the bones around with your hands. How do you do that? You said that you move the bones around the kneecap. How do you do that?
First, do it easy. So gentle. Because a lot of these people, you just touch, so that'll be all right. Let me just do this a little bit. Just a little bit till you can rock the kneecap a little bit. Have them take a step or two, come back. That same thing they wouldn't let me do before, now they'll let me do. As soon as I can get it up, where I can feel the edge of the kneecap, or feel the edge of the spur, now we're starting to get somewhere. Now I can start to stretch out, it's called the lateral retinaculum. That's the attachment that's holding, that's squeezing like a rawhide that's dried out, that's squeezing this kneecap down. I've got to get that looser. I'm not cutting it, I've just got to get it looser so your kneecap. Now once I get that looser, now I'm going to start to try to break down the attachments from the kneecap to the femur and the kneecap there. But you go nice and gentle, take your time, no rush, and you get it. And everybody who comes in the office, 95% are going to walk out with no pain at all. Keeping it is a different problem, but at least they're going to walk out and you know that you're going to be able to solve it. At least it appears you're going to be able to solve it. But they've got to, last more than 15 minutes. They've got to last eventually, months and years.
Question, if I don't have pain, and you were to see me, and you would be able to diagnose also whether or not there was a potential that I could have problems and correct it?
Sure, but I wouldn't correct it. I mean, if you're doing good, keep it that way. Leave it alone. You're trying to get somebody perfect. Doesn't always work, and you find that out, especially doing operative work. You put a, say, your kneecap that's shattered, you get it together. I said, that looks pretty good. Just one more turn of the screw to make it perfect. That turn of the screw, the whole plastic thing falls apart. No, but just, and if you're good, I'm not going to do anything with it. Now, if you've been bad, I get you good. Then you're going to do some major thing. You want me to treat you. The insurance companies all say, no, once every 3 months. Well, I can't fix anybody once. I need several visits. So fine, I'll absorb the cost. I would send in one bill, but I'll treat you the others several to get you started. After that, if I can't get you so you can keep it, I'll let you know. I give up, I can't do it. If I have reason to think I can help you with the injections, I'll do that. The injection we're talking about, the Hyalgan. But a lot of people are resistant. I don't believe you can do anything. I'm a skeptic. What do you think of that, doctor? I don't believe it. Well, okay. I'll try, and they say, yeah, see, I told you it wasn't going to work. But you've seen that it worked, so you go, well, I'm sorry, sir. Oh, ma'am, I just can't help you. You have to find another doctor. Yes?
Reattached quad tendon.
Beg pardon?
Reattached quad tendon.
What
Where
about it?
the quad tendon released, they had to drill hole to the patella and reattach the quad tendon to the patella.
Sure.
What would you recommend?
I'd reattach it.
Well,
Who's it? Clinton comes down the steps at in Palm Beach. He separated his. He had to have it reattached. Your leg's no good if you don't have a quadriceps tendon.
Had it reattached. But is there a possibility that the alignment would not have been properly aligned during the reattachment?
Sure. But you do the best you can.
So what do we do from there?
I've never had one that didn't work. I was a pretty good surgeon.
I've known him for years. He was always the knee guy when I
Well,
always did knees.
well, if you get a doctor who's never done one before,
Haven't
doesn't know
done
how
knees
to
in a
patch
while,
it,
but
and can't get it
good.
lined up,
Did
then
knees
what do
real
I do
good.
about that?
Didn't do a lot of back when I knew.
If the kneecap is off, I can probably help you out, but I can't make you well.
Question in a better manner. I have a
Yes.
Yeah, I don't really have pain in my knees, but once in a while when I go upstairs, or after I do like squats at the gym, that my knees burn pretty good. What do you think that's?
Have patience, I'll be seeing you. You don't need to do anything now. Wait,
Like, do I need to come see you now?
no,
That's preventive?
you don't have enough. Then you say, listen, and they came when I walked in here, what have you done? You've done nothing for me. You gotta come in with the pain. I don't treat people who don't have pretty close to constant pain, or they're incapacitated because they want to run a marathon. They don't have pain walking around, but they can't run. I'll take them.
I was just wondering why that burning little flare that I could.
Your kneecap that's the one that burns. Your kneecap hitting the side is burning.
And there's nothing preventative or that I should do?
I'm sure in here 15 people got some advice for you.
Okay.
I have no advice for you. Let me know when it gets bad.
Question over here.
Yes.
What's the role of heat or cold therapy with pain? Which would you use first?
Right after your injury, cold, positively cold. Your knee, after the injury, you're doing bleeding. Those blood vessels want to contract. The ice helps them contract. You put that in heat, the blood vessels open up and increases your swelling. Feels really good, but you make yourself worse. For about the first 4 or 5 days, it's ice, and then after a week or so, then you may go to heat. But that's kind of a general rule.
Yeah, go ahead.
Ice initially, heat afterwards. Yes.
Is your procedure painful? Does your knee bruise after that? It's not painful, the manipulation? People don't.
It's uncomfortable
It's uncomfortable.
to a lot of people, and others just laugh, and when are you going to get started, doc, and that kind of stuff. So the macho guys, men and women, hey, that's okay. Go ahead, doc. Do your job. But if you go slow enough, it will be, if you go slow enough, it won't hurt. The same way that you can't touch the knee. If you go slow enough and just barely touch it, all of a sudden you can do more and more and more and more with it.
Are you training other doctors to do this? Because this seems like a procedure that you should definitely train others to do.
It certainly seemed that way.
Yes.
It doesn't work out. Medicare in Florida says, no, don't do that. We will not pay for preventive care. We will pay to have your knee replaced. We will not pay to prevent it. So you're just fresh out of training, and you got that knife in your hand, man, where's the first patient? Why don't you go with Doc Barry over there? He'll show you how you don't have to operate. Oh, yeah, sure. No. That's a waste. There's no money in what I'm doing. There should be, but you can't train a guy. Fortunately, I had a huge knee practice, and because I got so good, I had no knee surgical practice at all. If I say, okay, I'm not going to do this anymore, fine. I've been running my office at a loss for 4 years. That's, and there's no surgeon running at a loss. So he's doing well now. He's not going to try to learn. And first, he's been trained like I was. Look at that X-ray. That X-ray says you gotta have surgery. I had a nurse who came out of retirement because I got her so good. She goes back to work. She's doing the Canadian Air Force exercises, and the doctor calls and wants to see her. So she goes in. So, oh no! Look at that X-ray. You gotta have surgery. Okay, doctor. They bulldoze you, intimidate you into having the surgery. Well, I want to go see Dr. Bear. Oh, no, he doesn't know what he's doing. That's he's hypnotizing you. No, that doesn't work. I had a fellow who was good for a couple of years, and he was in Tampa, and I was going to Tampa. I saw him there. Good, last couple of years. Goes his doctor before told me he's sitting in your place. I said, no, we'll fix you up. We'll fix you, and you don't have to see him anymore. Well, he fixed him okay. He came in about 6 months after his operation on both knees, on crutches. And he's fixed up okay. They should have given you a business card.
It's on the handout.
Am I done with all the hands?
I have a question. We got a question. Maybe I missed it. I was wondering what the connection is between me and the fibromyalgia. I can't say it. Fibromyalgia. How does it well? That you said about that.
1 month ago, I was at a lecture up at Columbia University. As the head of the biology department, and the lecture was called Ignorance. And it starts off with, if you're in a dark room, like you turn off the lights, and you're in the dark room, and I tell you there's a black cat in the room, find it. You search here, and you search there, you can't find it. Maybe there's no cat in the first place. I do not know why rubbing that bone way down in there all of a sudden gives you the flush, short of breath, and all of a sudden everything goes. Is this, when they talk about autoimmune, is this a self-protective mechanism? 4, 5, 6 months ago, there was an article, one of the magazines had this tribe in Venezuela or Brazil, and they move on, they've got to keep moving. But this woman couldn't keep up with them because of her, I gathered, her needs. So they deliver some food, and they were behind. You've got to stay mobile. Now, if your knee starts to act up on you, if it can do something else, you get the knee pain so you cannot keep up with the tribe, you're left behind. Evolution says survival of the fittest. So if your knee will then give you something else because of your knee, peripheral neuropathy or fibromyalgia or something where you can still walk, you keep up with the tribe, those people will survive. Those people who still have the bad knee just progresses on, they don't survive. So I don't know if all these things may not be a self-protective mechanism that your knee is doing to keep you alive, make you survive, and then all of a sudden, by going in a place that your knee used to go, and has never been in for years and years and years and years, and rubbing those bones together, whatever is released that makes you flush and get a little dizzy and makes all this go away. Is this a survival, or is this a, I don't know. I'm looking for the dark cat in a black room. I don't know what it is. I don't have the answer.
I want to thank you for your answer, and I feel it's the same lady way over here.
Okay.
And I want to share with you that I learned a technique where I can hold the top of my foot back like this, and in seconds I can clear nasal congestion.
Terrific.
Yeah, I don't know how or what's working, but it works.
Don't look at me. I don't know either. No. Pardon? No, I have no idea. All these people tell me how much better they get. I didn't believe any of them. But over and over and over again, you say, finally I got to listen. The same way when I did the first one, I didn't believe it. That doesn't mean that all of us can't stretch out our toes and make our nasal congestion clear. But I don't know how to do it. So if you can teach a couple of your friends how to do it, you're onto something.
Okay.
If I could bottle whatever it is that causes this dizziness and causes these things to get better, we'll all be trillionaires. So whatever that substance is, I don't know. Is it maybe releasing? We know that there's something called the type of cell, in the brain, Alzheimer's disease. No, I know that, we're talking about the deposition of amyloid. A lot of these areas have amyloid in them. Am I really clearing the amyloid long enough for their wrist to move again and the nerves to be free? Maybe it's amyloid. I can get a lot of the Alzheimer's patients who are intractable, they're unmanageable. And if I can get rid of their knee pain, they become much better. I've not done enough of them or followed long enough to see if I'm making any change in. Because everything I do, I get a hard enough time just doing the knees. All the side effects that I'm having, these positive side effects, I'll need a government grant to get that, because that's, I'm giving so much, as I said, I'm running at a loss. I cannot afford to take on other than what I'm doing.
Fallen arches or flat feet, how does that connect to the knee? If the knee is released, would that change the arch?
If you have flat feet, the chances are good you've got ligamentous laxity. That means that you've got extra motion in your wrist. You can take your thumb and bring it down to your forearm, and you get the same thing in your knee. The ligaments which hold your kneecap in place aren't doing their job, and your knee starts to slip off to the side and stay itself enough there, it starts to scar down. Your flat feet are a reflection of your generalized ligamentous laxity. And all kinds of shoe wear, if they hurt, fine. If they don't hurt, there's nothing you can do for flat feet. We got 100 operations you can do for flat feet. Why do it if your feet don't hurt? You'll get in bigger trouble than you were before you got started. And so restoring you to a normal gait, your feet don't like it, your ankles don't like you walking like this, your sacroiliac joint doesn't like it, nothing likes you walking like this. You return to normal, start walking straight and true, and the foot pains go away, the ankle pains go away, back pains, a lot of things get well. I fixed more bad backs with what I'm doing with knees than I ever fixed with a scalpel. I thought I was pretty hot with a scalpel.
I've got one question. What about crossing our legs for hours, like most people do? Crossing our legs.
So what about it?
Well, is it a problem? Does it do anything with the knee? I mean.
No. If your knee hurts, you can't cross your knee because
A
you're
chiropractor
crossing
told
it.
me never to cross
Your
my
kneecap's
legs.
got to move, and if it won't move, you can't cross your leg, you can't get your socks on, you got to double the time. But not crossing your legs, because it might do something. I don't think anybody, I've not seen it anywhere in the literature that you shouldn't cross your legs.
Thank you.
I mean, you make yourself numb, you hurt, you pressure on the nerve, you made it fall asleep, but not permanent damage in your knee.
Thank you.
Dr. Peters, just one more question, and then we'll wind it up, because I know you're going to be, people are going to try to rush you before you get off the stage, so we need to wind it up so you can have some free time afterwards.
Yes,
Do you recommend supplements?
I'm sorry.
What supplements do you recommend?
Well, the most well-known is the chondroitin and glucosamine and listen, if it worked, I'd be taking it. And if it worked, I'd be giving it to all my patients. No study done by anyone other than the company who makes it has ever demonstrated it works. That doesn't mean that you may not feel better. That's fine. I'm glad you do. There's something called the placebo effect. But no one has been able to demonstrate medically that it works. And when it first came out, boy, that's really great. And I took it, and I couldn't see the difference, and I finally quit. But that was before we found out that the only positive reports came from the company itself. Like the only people who say smoking is good for you is R.J. Reynolds. All right? I want to thank Dr. Barry for this great talk.
think a very special part of it was his sharing his discovery process, which a lot of doctors generally wouldn't want to do that. But I think all his experience and seeing how he actually had stages of discovery with learning how the hands-on technique was effective and became more and more of an art that you really discovered and established for yourself. So I give you a lot of credit